Hi there, this is Miss Walton. Today we're going to be discussing alterations in the eyes, ears, nose, and throat with pediatric patients. When we discuss the eyes of the newborn, keep in mind that visual acuity is between 2100 and 2400. So when we talk about visual acuity, 20/20 vision is a term used to express normal vision acuity measured at 20 feet. If you have that 20/20 vision, you can see clearly at 20 feet what you should normally be seeing at 20 feet. So for example, if you have 2100 vision, that means that you have to be as close as 20 feet to see that object when normal people could see that object at 100 feet. So their lens cannot accommodate. So they see best at a distance of 8 inches. They prefer black and white and red colors, and then they're able to see pastels by the time they're 6 months old. The optic nerve is myelating, so the ability to distinguish those colors and detail is decreased at this time. And then you will also see some eye color changes during the first 6 months of life. So here you have some developmental milestones as far as eye development. So you can read about those and do that part on your own. So now that you've reviewed a little bit about the eyes of the newborn and looked over those development milestones, we've got a question. So go ahead and pause the video and figure out what you think the answer is, and then I'll tell you. The answer is B. It usually begins around 3 months of age. So now we're going to look at the childhood eye development areas. And so during this time in childhood, when they're 2 to 3 years, their vision is 20/50, and by the time they are 6 to 7 years old, their vision is actually normal, and it is 20 to 20. So normal vision, whatever you can see at 20 feet, that's what they can see. When they're 2 to 3 years old, they have to get closer at if it's 50 feet away. So the first disorder that we're going to talk about is conjunctivitis or pink eye. This is very common in children. It's caused by a virus and bacteria such as chlamydia, gonorrhea, strep. Allergies can contribute to that. Trauma such as contact lenses and foreign bodies, and irritants and chemicals. Kids like to pass around pink eye. Some symptoms that you will see with pink eye are itching, burning, a discharge, crusty eyelids. Their sclera is normally pink, and they are still able to see. Treatment for this is, if it's bacterial, you're going to give antibiotics. And then depending on if it's viral or a herpes simplex virus, there may be something else given for that. If it's due to allergies, they can have antihistamines. Is usually the most common for that. So with this, you want to do some teaching. So it's very contagious. You do not want to share any towels or washcloths. You want to administer medication into the lower conjunctival sac, cleanse the eye from the inner canthus to the outer canthus, and make sure that there is meticulous hand washing, and you want to also keep them at home for at least 24 hours. So keep in mind, whenever you are administering the antibiotic ointment, you want to kind of discard the first little bead because it can be contaminated, and then you're going to just put a small ribbon from the inner to the outer conjunctival sac. Again, you want to avoid rubbing eyes and maybe keep those contact lenses out for a while, and not use any eye makeup. All right, for this question, the nurse prepares a teaching plan for the mother of a child diagnosed with bacterial conjunctivitis, which, if stated by the mother, indicates a need for further teaching. So what is this question asking you? It's asking you, what is the wrong answer. The answer is C. It is okay to share towels and washcloths. They would definitely need more education because we don't want them to share towels and washcloths because this is extremely contagious. Okay, next question. The nurse is assessing a child with conjunctivitis. Which of the following symptoms would the nurse most likely assess? What are you going to see? You're going to see D, crusting of the eyelids and eyelashes. Next, we're going to talk about cellulitis that is periorbital. This can be caused by an infection of the eyelid and surrounding tissues. It's usually bacterial. Some signs and symptoms that you will see is swollen, tender, red, purple eyelids, restricted painful eye movement, and a fever. The treatment is going to be IV antibiotics. And just keep in mind, this is a very serious disorder because it can lead to bacterial meningitis. Now we're going to look at visual disorders. Keep in mind when both eyes do not function together, the brain cannot make sense of the image, and therefore the child will have altered vision. So diagnosis and treatment of visual disorders is very important. So you want to seek prompt treatment to prevent any further visual loss. Hyperopia is farsightedness. Myopia is nearsightedness. Astigmatism is when you have a curvature of the lens or the cornea, and that isn't a spear shape. It causes blurred images. Strabismus is an inward or outward deviation of the eye, and it can result in amblyopia if not corrected, which is cross-eyed. Amblyopia is also called lazy eye. There's reduced vision and a weak eye in one or both of the eyes. Cataracts is also an issue, so that's when the lens becomes opaque and prevents refraction of light into the retina. Then you have glaucoma. That is an increase in that intraocular pressure that damages the eye and impairs vision, and it can cause blindness. Color blindness is also something seen in children and adults, most often in males, but that is the inability to differentiate certain colors. Red and green is pretty common. It's an inherited disorder by way of the X chromosome. It's less often seen in women because they have 2 X chromosomes, whereas boys only have 1, and it's handed down by the faulty X chromosome. So having 2 faulty X chromosomes is extremely rare. Now we're going to look at those visual disorders a little more in depth. So keep in mind that children do not often realize they're having trouble seeing, but sometimes they'll exhibit some different behavioral symptoms. So things like tilting their head, squinting, closing one eye, and then you can also see that misalignment if it's associated with amblyopia. So the first one that we're going to talk about is strabismus. That is most commonly called cross-eyed. So eyes are misaligned as a result of a lack of coordination between the amount of between and among the muscles that control the eye. So keep in mind it's considered normal in an infant until they're about 4 months old because those muscles are trying to get stronger. So with signs and symptoms, you can have them close one eye and look around at the room. You'll see some eye misalignment. They may have double vision, squinting, eye fatigue, headaches, loss of depth perception, and odd movements when attempting to focus on a specific image. So to diagnose that, you can do that cover-uncover test with the one eye, closing one eye to look around the room. So you're looking, when you do that, as the nurse, you're watching for any movement of the uncovered eye, and then you repeat the process on the other eye. So treatment for this is eye patching. So that is when you will patch the good eye. That way the weak eye is forced to focus and strengthen. If that does not solve the issue, then generally they will have surgery before the age of 2. They can also use Botox injections to paralyze the stronger muscles and allow that weaker muscle to strengthen. All right, let's look at this question. The daycare is observing a 2-year-old and suspects that the child may have strabismus. Which observation made by the nurse indicates the presence of this condition? The answer would be B. The child consistently tilts the head to see. Next up is amblyopia, or lazy eye. This can result from any condition in which binocular vision is affected, the same as with strabismus. So when the binocular vision is affected, the brain reduces the image from the weaker eye and only attends to the image from the stronger eye. And if this isn't corrected, the weaker eye will no longer send that image to the brain. And binocular vision is disrupted because the brain is receiving 2 messages as a result of the non-parallel axis. So you frequently see this in kids with strabismus. And keep in mind that a child can become blind in that weaker eye. So some signs and symptoms are squinting, odd movement when they look closely at an object, crossing of the eyes, and loss of that depth perception. Some treatment is occlusive therapy, or the eye patching, and contact lenses. So make sure that you are educating them about the disease and that therapeutic regimen, because think about little kids and how hard it would be, to use those corrective lenses, or, to keep that eye patch on. Kids don't want to be different than other children. Next up is retinoblastoma. This is a mutation of one or more cells in the retina. It slowly increases in numbers, and it results in a malignant tumor of the retina. Some signs and symptoms are a white reflex instead of a red reflex when light is being shined into the eye, or like taking a photo or something like that. You can also see the strabismus and altered vision. So treatment is going to be based on the size of the tumor and the extent of the metastasis, but generally it is surgically removed. And then sometimes the whole eye. And then also chemotherapy is used. And so if this cancer has metastasized, the prognosis is not good. So you want to catch this early. So now we're going to talk about some signs of visual impairment. So with infants, the infant may be unable to follow lights or objects. They do not make eye contact or have a dull, vacant stare, and they do not imitate facial expressions. As far as toddlers and older children, they might rub, shut, or cover their eyes, tilt their head or thrust their head forward, blink frequently, hold objects close, bump into objects, or squint. So be sure when assessing these children that you're listening to the parents and you're paying attention to the details of the child. They can't tell you that they can't see very well because they don't know. I had a patient one time who his parents were not aware that he could not see, and they caught it at a wellness checkup. He was older, I think he was around 5 or 6 when they caught it, but the mom said she felt so bad because when they walked outside, he looked up and he said, "Oh, I didn't know that there were lights on the top of those poles." So, keep in mind how this may make parents feel as well. We're going to talk about ear anatomy and development. So the eustachian tube in infants is proportionally shorter, wider, and more horizontal than in children and adults, which makes them more susceptible to what? Ear infections, right? So keep in mind that babies can hear by 20 weeks gestation, and they can recognize voices. So this is very important. During sucking, yawning, the tube briefly opens, allowing free passage from the nasopharynx and middle ear, and this passage is what predisposes those infants to otitis media, or an ear infection. So you need to remember that all newborns can hear. So here you just have a refresher of ear anatomy and development. So go ahead and look at the two different diagrams. You can see the differences between the ear at 2 years of age and then at 12. So I'll let you take some time and read this and be familiar with it. Up next, otitis media. What is that? It's an inflammation with or without infection of the middle ear. Nearly all children have one by the age of 7. The peak incidence is within the first 2 years of life, and those risk factors for that is that the eustachian tube has a dysfunction. It could also be due to formula feeding, attending daycare, exposure to cigarette smoke. Some protective factors with that is going to be vaccines, breastfeeding, not smoking, and then isolating babies from sick individuals. Symptoms that you might see are ear pain, tugging at the ear, redness of the tympanic membrane. They make awesome little otoscopes at Walmart that you can buy for 20 bucks. And then the other thing would be middle ear effusion. So here we have what a healthy eardrum looks like. Here you see what acute otitis media looks like in the child. So here you have a picture of otitis media with effusion. Keep in mind that you won't need to install antibiotics if it's not an infection, but the treatments can be surgery, an adenoidectomy, or tubes in the ear. So once it's open or ruptured with otitis media with effusion, they will have instant pain relief. So that's something important for you to know. So treatment for otitis media, according to the American Academy of Pediatrics, they recommend with acute otitis media that they have antibiotics for 10 days in children less than 6 months of age. If they are 6 months to 2 years, antibiotic is administered based off of the severity of the illness. And if they're over 2 years of age, treatment is often delayed for 48 to 72 hours unless the child is severely ill. Treatment for otitis media is going to be, if they have an effusion, there's not going to be any antibiotics, and you'll see frequent follow-up. And then they also may need a myringotomy with tympanostomy tubes, and that may be performed after 4 or more months of age. So basically, these kids that have ear infections, you kind of just had to do some watchful waiting for about 3 months. If the effusion persists for a long period of time, the child is at risk for hearing loss, learning difficulties, and speech delays. So you want to keep an eye on this. We have another question. A 4-month-old child has been diagnosed with otitis media. The nurse should place highest priority on which teaching below? So the answer is B, and you want to do this because you want to make sure that you prevent on antibiotic resistance. Oftentimes, the ear will be starting to feel better. It's kind of a pain. Kids don't like medication or urine drops. So you want to make sure that you continue to do that so that they do not develop that antibiotic resistance. All right, so let's look at this. You're caring for a child diagnosed with otitis media. Effusion. What pharmacological management would you expect the child to be prescribed? What complications may cause concerns? Pause this and think about it. Otitis media with effusion is not treated with antibiotics. It could take up to 3 months to improve. This type of otitis media is associated with hearing loss, so frequent follow-ups may be needed to ensure that it improves. They also may need an audiology consult, and they could need those ear tubes placed. So you want to teach about the tubes if this happens. So you're going to want to wear earplugs for a bath because you do have that direct passageway with the tube, and then notify the healthcare provider if they fall out. It's not really an emergency. They usually fall out at about a year old, but you also want to make sure that they know to report purulent drainage. Now we're going to talk about otitis externa. So This is inflammation of the skin and soft tissues of the ear. Often you may hear it referred to as swimmer's ear. It can also be an ear. The irritated canal can easily get infected. Some symptoms are pain, itching, and swelling, and the treatment is making sure that you're cleansing, you're using antibiotic drops, maybe some steroid drops. So keep in mind that when you install those drops, if the child is 3 and older, you want to pull the pinna up, and if they're 2 and under, you want to pull the pinna down to change the shape of the ear canal to get the medication in correctly. We're going to talk about hearing impairment. So this affects about 1 million children in the United States. So every 2 children out of 100 births are affected. So it's defined by the severity. Some causes are genetic, environmental, and just sometimes it's unknown. Some signs and symptoms are hearing loss. That's usually picked up on a screening. So newborn screenings are very important. They like to do those before discharge. And then you may also see some delayed language development. So looking at those language milestones, no social smile, no babbling by 6 months, no words, but maybe mama and daddy by 18 months, no 2-word sentences by 24 months. So they're not meeting those developmental milestones. So we look at some causes. So as far as environmental, it can be caused by rubella, diabetes, and birth trauma. After birth, it could be caused by a CNS infection, head trauma, medication toxicity, or exposure to a loud noise. They could also have a conductive issue because of an injury, inflammation, or blockage, such as earwax infection or foreign body. And then it can also be sensorineural. So that might be caused by injury or a deficit of the inner ear or the auditory nerve. I did have a patient who was not immune, did not get any vaccines. Her brothers brought home rubella, and she ended up getting it and was deaf. She was also blind, had cataracts. It was a very sad situation. So importance of immunizations are extremely important in those cases. So as far as assessment and treatment, when assessing those children, you might notice that the infant doesn't startle to loud noises, they don't turn their head to sound, there's that little to no babbling or vocalizing. With toddlers and preschools, they may communicate through gestures, have little or no speech, developmental delays, or no response to a doorbell or telephone. School age and adolescents, a lot of times you'll see that they'll sit closer to the speaker or they turn up the TV volume really loud. You see that poor school performance, speech problems. They can't correctly respond except when able to see the speaker's face. So some treatment, early identification is definitely something that we want to focus on. Hearing aids, cochlear implants, and then, keep in mind that some forms are not treatable. So hearing aids amplify the sound. Those cochlear implants transmit sound to the auditory canal. Speech therapy is something that these patients can also benefit from, as well as learning sign language. So go ahead and read this, pause it, and then I'll give you some feedback. So keep in mind, school age and adolescents sit too close to the speaker. They turn up the TV volume loudly. They have poor school performance, speech problems, and can't correctly respond except when they're able to view the speaker's face. You see some difficulty understanding conversations among peers, and that prevents them from expressing their self and joining in on play. They might avoid some social interaction as well. So keep in mind, if their play is hindered, their learning is going to be hindered. Okay, now we will move on to ailments or disorders of the throat. First thing we're going to talk about is pharyngitis. This is an infection of the pharynx, often involving the tonsils. So as far as etiology, it's a common disorder in children 4 to 7 years of age. 80% is viral, and with bacterial pharyngitis, it's usually caused by group A beta hemolytic streptococcus, so a lot of strep throat out there. Some signs and symptoms are sore throat, difficulty swallowing, drooling, caused by a sore throat, inflammation of the pharynx, enlarged tonsils, and lymphedema. All right, so when diagnosing pharyngitis, they usually do a throat culture using a swab, and they swab for strep throat. For treatment, viral and symptomatic or things like that, you're going to have a soft liquid diet, no citrus juices or other foods, because that can burn the throat, saltwater gargles, throat lozenges, anesthetic sprays, Tylenol, ibuprofen. If it is bacterial, they're going to get antibiotics. Generally, amoxicillin is the drug of choice, or penicillin or erythromycin. So some nursing considerations. So make sure that they complete the full dose of antibiotics if treated inadequately. Strep can result in acute rheumatic fever and glomerular nephritis or other serious issues. So, with this, some precautions would be no solid foods for 72 hours. Make sure they're changing their toothbrush after 24 hours of the antibiotics. They won't be contagious anymore, but you want to encourage them to not share food or drinks and have good hand hygiene. With rheumatic fever, that is an inflammation affecting and an autoimmune disease that affects the connective tissues of the heart, joints, skin, blood vessels, and central nervous system. The most serious are the cardiac valves, like the mitral valves. This can occur 2 to 6 weeks after an untreated strep infection. That's very important for you to know. Glomerular nephritis, this is an inflammation injury to the glomerulosis. It's a destructive inflammation of the kidney, and this usually occurs 2 to 3 weeks after a strep infection and can lead to kidney failure. The test they'll use will be a positive anti-streptocin O titer. Again, very important for you to know. You're going to need to know that later on. Okay, here's another question. Pause and then I'll tell you the answer. The answer is B. The child must take all of the antibiotic. So penicillin V is oral, and keep in mind that penicillin G is IV or IM. Now we have a critical thinking question. Pause, and then I'll give you some feedback. So you want to make sure that they complete all of their antibiotic as ordered, because if the sore throat persists, return to the medical doctor. You want to prevent the development of any other infections, such as rheumatic fever, because that can lead to endocarditis and the valve disease, right? So don't share drinks, good hand hygiene. They're contagious until they've had 24 hours of antibiotic therapy, and make sure that you're having them change their toothbrush. Now we're going to talk about tonsillitis. What is this? This is inflammation of the tonsils located in the posterior pharynx. So it can be viral or bacterial. Some signs and symptoms are enlarged reddened tonsils with or without exudate, sore throat, difficulty swallowing, drooling, lymphedema, and then mouth breathing. So when diagnosing tonsillitis, you're going to do that throat culture, checking for strep throat, and then treatment will be viral, just kind of symptomatic, so same as viral pharyngitis. If it's bacterial, of course, they're going to get some antibiotics, and the nursing considerations are going to be the same as pharyngitis. All right, so now we're going to talk about a tonsillectomy. What is this? This is a surgical removal of the tonsils to prevent recurrent tonsillitis. So it's indicated when they have that recurrent tonsillitis, or if they have some abscesses on their tonsils or respiratory compromise. So when you're completing your assessment, the child should be free of tonsillitis 1 week before they have surgery. So this is rarely performed before a child turns 3 because young children bleed more heavily during surgery and experience tonsil regrowth. So this slide's pretty important for you to know going forward with a tonsillectomy. When we think about preoperative nursing care and that family and patient teaching, so we want to definitely talk to them about that, let them know that they're typically discharged soon after surgery. As far as post-op nursing care, pain control and ice collars are very important. If you see on here, you notice some bold letters, you want to be monitoring for excessive bleeding or hemorrhage. That's going to be frequent, continual swallowing. So you're going to see that child trying to swallow, bright red blood, and changes in their vital signs like tachycardia and hypotension. You also want to be offering clear, chilled fluids, non-citrus and bicarbonated fluids. Avoid red, purple, or brown fluids. You don't want that to be misinterpreted as blood. And you also want to avoid milk products. That just kind of, makes it a little bit more like the saliva more thicker and sticky and things like that, because it does increase the mucus and it will cause them to clear their throat more. So you want to start out with those clear liquids, and then you can advance their diet slowly to a soft diet during the week that they had surgery. You don't want to use any straws or forks, no coughing, gargling, or throat straining. Give them pain medications. Do not suction them. The only time you would suction if there was an obstruction. And then again, I said no red colors, no purple, no things like that because it might look like blood. You want to make sure that you're monitoring respiratory function and infection. So keep in mind a low-grade fever is normal with these patients. So some more teaching that we will do with tonsillectomy is, they're probably going to have a sore throat for a week. You're going to be giving them that pain medication. You're going to be monitoring for complications such as hemorrhage. What were those? Frequent swallowing, right? And then adequate fluid intake. Kids don't want to swallow, they don't want to drink because their throat hurts. You also want to encourage them to advance their diet as tolerated. You don't want to give anything that might irritate them, so no acidic foods, and then no strenuous activity for 7 to 10 days. You don't want them to strain the throat. You want to discourage that coughing, clearing of the throat, or nose blowing to prevent that bleeding. You want to position them in a prone or side-lying position. You want to have suction equipment available right after surgery. You want to be administering those antiemetics. You don't want them to get sick at their stomach and throw up, cause more trauma. And then just make sure that you're educating the patient that there is going to be mouth odor. There could be slight ear pain and a low-grade fever in a few days post-op. Okay, a child's being sent home after a tonsillectomy. Which of the following actions would the nurse educate the parents to perform? A, right? One of the most common things that you want to teach them is to monitor the child for excessive swallowing. Why is that? That could be a sign of hemorrhage. Kids don't have a lot of blood volume, right? So they can become hypovolemic very, very quickly. Check out this critical thinking question. Your patient's a 5-year-old, 2 hours post-op tonsillectomy. You enter the room to get your vitals. The patient awakens, frowning, asking for the mother. She refuses to drink any fluids, reaches for her throat, and begins to cry. Do you need to call the physician? What concerns do you have and what interventions should be implemented? I'm going to assume pain, right? What do you do for pain? You give Tylenol with codeine. You can also give cold fluids like popsicles and try to give things to kids that they might like. So, you want them to drink. Drinking lots of fluids is very important, but keep in mind you don't want any red, anything that's red. You also do not want to give NSAIDs, and you also have the option of an ice collar with these patients.